Dr. K K Pareek sir, ex-president API, ex-dean ICP, president Constitutional Committee of API, and founder president of RSSDI. Dr. K K Pareek sir is more than this for all of us. He is the mentor and fatherly figure of physicians of Rajasthan. He has been source of inspiration to all of us for last 30 years. He has been continuously motivating us for CMEs, seminars, and his motive is to disseminate knowledge. Without wasting time, I request Dr. K K Pareek sir to say few words of blessing to all of us.
Thank you, dear Keswani sahab, for your kind words. Welcome all delegates and panelists, young panelists, and our my dear friend, my younger brother, Dr. Girish Mathur, past president API, Dean-elect, Indian College of Physicians, and a great physician on this case-based discussion in diabetes. I also take this opportunity to welcome Dr. Prakash Keswani, the person who is sparing his valuable time and doing great efforts to disseminate knowledge to all our friends in Rajasthan, outside Rajasthan. I extend my sincere thanks to Dr. Prakash for his great work which he is doing to disseminate knowledge about diabetes. Thank you, dear, again. I also welcome Dr. G D Ramchandani, who is holding and doing great hard work as a secretary RSSDI for last so many years, and he has done a lot of service to the RSSDI Rajasthan chapter, and his contribution cannot be forgotten by all of us. We have got very young, dynamic panelists today. Dr. PARTH JETHWANI, who is at this young age, is an excellent orator and has got good knowledge of diabetes and endocrinology. I hope that he is going to be a very dynamic endocrinologist of the, not only for state, also for the country. The young generation is really doing great. Ashutosh Chaturvedi, we all know that he is a very dynamic orator, as well as he is a hard-working person, done good job as a joint secretary to the president, and now he'll be the joint secretary to the dean. Ankit Manglunia, probably he is not here because of his some emergency call from Guwahati. Abhishek Prakash, consultant endocrinologist, a very reputed endocrinologist of the state, and our dear friends, colleagues, Dr. K K Sharma, Dr. Kedia, Dr. Rajendra Kumar, Geeta Arora, who she's always attending this CME program. Daria is also very young and dynamic person who is doing great job to the API Rajasthan chapter. So Prakashji, I
Thank you,
really
sir.
admire and thank you so much for
Thank you very much, sir.
the work you are doing, and you are keeping
No, sir, this is all because of your
engaged in
blessing.
this scientific program. Thank you so
And
much.
thank you, sir. Thank you for your kind words. Now I invite Dr. Girish Mathur, sir. He is ex-president API, Dean-elect ICP, ex-chair Raj RSSDI, His continuous efforts only has taken Raj API to present heights. This program of case-based discussion was started with his inspiration during his tenure of the chair at Raj RSSDI. And it's his motivation only that we are continuing it for last 16 months. Without wasting time, now I request Dr. Girish Mathur sir to bless us with a few words. Mathur
Thank you,
sir.
Prakash ji, for the kind words. Good evening, friends. It's my pleasure again to be part of this highly successful program of case-based discussion organized by Rajasthan RSDI. My sincere thanks and my warm regards to our mentor and patron, Dr. K K Pareek sir, who is always there to support us and bless us in every academic endeavor of ours. This case-based discussion program is wholly conceptualized and executed by the highly energetic Chairman of Rajasthan RSDI, Dr. Prakash Keswani. I salute his zeal and persistent efforts in organizing this program months after months very regularly for more than a year. I also compliment the sincere efforts of our Secretary, Dr. G D Ramchandani. This program is not only benefiting us with the updated knowledge in the field of diabetes, but also providing a platform to our younger, talented friends to showcase their ability and skill. Today, I welcome one of such young, talented endocrinologist, Dr. PARTH JETHWANI from Kota. I'm sure Dr. JETHWANI is going to enlighten us with his academic excellence. I also take the pleasure to welcome today's distinguished panelist, Dr. Ashutosh, Assistant Professor, Medicine, Mahatma Gandhi Medical College, Jaipur, Dr. Abhishek Prakash, Endocrinologist, Manglam Medicity Hospital, Jaipur, and Dr. Ankit Manglunia, Consultant Endocrinologist, Saket Hospital, Jaipur. I extend my warm greetings to all participants and wish a great success to the program. Thank you so much, Prakash.
Thank you, sir. Thank you very much for your kind words. And I request Dr. G D Ramchandani, our dynamic secretary, to conclude at the end of the session. And now we move towards the scientific program of the today. I invite Dr. PARTH JETHWANI to start, please, your case presentation.
Thank you, sir. I'll just share my screen. I hope my screen is visible and I'm audible.
Yes, sir. Visible and audible both.
Right. Thank you, sir. So the topic that we have today for discussion, the case that we have is a young onset patient who had presented to us at AIIMS when I was doing my residency. So I'll start off with the patient particulars. First of all, before starting my case, I want to thank each and every one, which I'll be doing at the end of my presentation as well. Starting off with Dr. K K Pareek sir, who has been instrumental for me right throughout my MBBS and MD journey as well, when I would often go to him for advice. So for me, it's an absolute privilege and honor to be speaking in front of him and now discussing a case on diabetes. Right from my MBBS days, and even before I started my practice in Kota, I visited sir, and I've always looked up to him for guidance. So thank you, sir, for being present and for guiding me throughout. Dr. Girish Mathur, sir, whom I visited and very recently again when I was doing my practice for guidance. Dr. Prakash Keswani, sir, for giving me this opportunity, and the panelists, Dr. Ashutosh, sir, and Dr. Abhishek Prakash, sir, again. So with this, I'll. Hello. Yeah, so I'll just start off my case, sir, with your permission, sir. Dr. G D Ramchandani, sir, as well. I've recently gotten in touch with sir. So again, it's a privilege and honor to be presenting this case in front of such stalwarts. And with your permission, sir, may I now start? Just confirming, I'm audible and I'm visible, right? Can I
Yes,
start my
Parth,
presentation?
you are audible. I think we can start.
Right. Thank you, sir. So I'll start off with this patient. So we had a 23-year-old male who was a worker at a cloth store. He was a resident of Nagaur, not married at the time. He presented to us with a total duration of illness of 8 years. He was diagnosed with diabetes for the past 8 years, with his age of onset being 15 years. He was managed largely as a case of type 1 diabetes, where when he presented to us, he was on a basal bolus insulin regimen, and this was at the time in December 2022. Now, starting off with his diabetes, so the complaints that he presented to us primarily were multiple symptomatic hypoglycemic episodes, which he had around 3 to 4 times per week. He also had complaints of a hearing loss in the right ear for the past 4 years, and he also complained of reduced vision in both eyes for the past 5 years. Now, coming to his history of present illness, and I'll try and take you through 2015 up till 2022. So I'll break it down into two parts for you. Initially, we have a history from 2015 up till 2018, and then from 2018 up till 2022, where he presented to us. So in the initial part where he was diagnosed, that was in 2015, he was 15 years of age, and he had osmotic symptoms at that time in the form of polyuria, polydipsia, and weakness. His blood glucose at the outset when he was diagnosed was 450 milligram per DL. There was no history suggestive of DKA, and he was started on oral medications, again, the nature of which is not known, but he was largely non-compliant for these initial 2 years, and there were no glucose measurements as well done during this time. Thereafter, where in 2017, he had a episode of fever, generalized weakness. His urine ketones, as he mentioned, were negative. And then he was thereafter started on a basal bolus insulin regimen, which again, as is often the case in an Indian setting, he took irregularly. Thereafter, he in November 2018, that is after around 8 months, he again had a history of fever with weakness. We had reports of that time, and his pH was 7.3 with a bicarb of 17.3, and urine ketones were again negative. He was then subsequently discharged on a basal bolus insulin regimen. So this is the time from 2015 up till 2018, where this patient was initially started on OADs to which he was non-compliant, and thereafter he was switched to basal bolus insulin regimen, to which again he was non-compliant. Now, moving forward from 2018 to 2022, that is December 22, when he presented to us, he was on a basal bolus insulin regimen, but as is very often the case in an Indian setting, he was taking his insulin irregularly. The administration was inappropriate, and with this complaints he presented to us, and we then went ahead to look for negative history. There was no history of recurrent abdominal pain. There was no history of chronic diarrhea. There was no history of steatorrhea, abdominal distension, or flatulence. There was no history suggestive of features of hypo or hyperthyroidism. There was no history of anorexia, weight loss, postural dizziness, or any hyperpigmentation. There was no history of paresthesias, recurrent infections, or oral thrush to suggest any polyglandular syndromes. We looked at the secondary causes of diabetes, so there was no history suggestive of Cushing's or acro. Thereafter, we specifically asked him for complications of diabetes, and what he mentioned was that he had a history of reduced vision for the past 2 to 3 years. There was no history of headache, floaters, or any previous laser therapies or injections which he had received. He also complained of tinkling sensation in the bilateral lower limbs. However, there was no history of cotton wool sensation, spin prick, or sensory loss or weakness, or any slippage of slippers while walking. There was no history of any autonomic symptoms as well, in the form of postural giddiness, palpitations, postprandial fullness, bloating, or any irregular bowel habits in the form of alternating diarrheas or constipation. Again, in terms of his macrovascular complications, there was no history of chest pain, palpitations, intermittent claudications, or any current or past history of foot ulcers. There was also no history of decreased urine output or any generalized body swelling. So then we inquired about his hearing loss. So he had an insidious onset gradual loss in his right ear for the past 5 years, where he felt that the intensity had now increased, where he was not able to hear even normal things from his right ears. However, there was no history of any associated ear discharge, trauma, or any ototoxic medications as such which we could get. Now, coming to his past and personal history, as I have mentioned, he had two history of hospital admissions in 2017 December and then November 2018. But besides that, there was no other any significant past history. He was a vegetarian with no history of addictions to tobacco or alcohol. Now, we inquired about his family because in a young onset diabetes, it often becomes important But again, there's a caveat over here. But at the outset, he had three other siblings, all three brothers. He was the third order. There was no history of diabetes in them. And when we inquired, now there's a caveat over here, which I'll present as I go on to my subsequent slides. But when we inquired, there was no history of diabetes in his family. And his grandfather, paternal and maternal, both had died due to cardiovascular diseases. Now, coming to the physical examination, so he was conscious with the blood pressures which were normal. There was no postural variation. He was afebrile. His BMI was 19.3, and there were no signs of acanthosis resistance, or essentially meaning there was no signs of insulin resistance. His waist circumference was normal. There was no abdominal obesity, and there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Now, uh, coming to the other part of the physical examination, his visual acuity was 6/6 bilaterally with refractive correction. On slit limb examination, we found the people found a bilateral posterior subcapsular cataract. His fundus was normal. Coming to his CNS examination, there was loss of fine touch in the bilateral feet up till ankle. But apart from that, other central nervous system examinations such as cranial nerves, vibration, proprioception, and pain and temperature sensations were intact. His motor power in the upper limb as well as the lower limb and his tone was normal. So, and we also looked at the other systemic examination because it often becomes important, specifically in a young onset diabetes. So his per abdomen was normal. It was soft, non-tender with no organomegaly, and his cardiovascular and respiratory system was normal as well. So we then moved ahead with a routine biochemical evaluation, which we get done. And in this, it was largely insignificant. His hemoglobin was 14.4 with a creat being 4.76. His SGOT and PT was 25, which was again normal. His total protein and albumin was again normal. And the ultrasound abdomen, which we had done, the pancreas were normal. And both the kidneys were normal in size and echo texture. In ophthalmological evaluation, as I have mentioned, there was a posterior subcapsular cataract. Now, this is where this is the slide where I want to draw your attention to moving from history examination to the biochemical investigation. His HbA1c, as you can see, is 9.8. His LDL was 107 with triglycerides of 64. He also had urinary microalbuminuria with his urine albumin creatinine ratio being 62.5. Apart from that, we also got a workup for his thyroid profile and IG anti-TTG done, which was again normal. His vitamin D, as is very common in an Indian setting, was very low. That was 4.4. So we got a pure tone audiometry done for his hearing loss. And as you can see, in the right side, you see that that is marked by red. That is the red here. So there was moderate sensory neural hearing loss, and this was with good reliability. In the left side, the hearing was largely normal. It was only at high frequencies that his hearing was slightly affected, but it was predominantly a right-sided moderate sensory neural hearing loss. So if I have to make a working diagnosis of this case, so we essentially had a 23-year-old male who presented to us with a diabetes mellitus for the past 8 years, with the age of onset being 15 years, with a normal BMI, with no signs of insulin resistance, with a right-sided hearing, sensory neural hearing loss, with a poor glycemic control, with distal symmetric sensory motor polyneuropathy, with microalbuminuria, and bilateral posterior subcapsular cataract. So this was the working diagnosis for us. And when we talk about the etiology of diabetes, which I want to draw your attention to, and which I specifically want to highlight in today's presentation, we initially at the outset, as most of us would, essentially kept a diagnosis of type 1 diabetes, with points in favor being that there was no family history he presented to us at such a high young age. But again, there were points against it, in the sense that throughout this 8 years, he did not have a single episode of diabetic ketoacidosis, despite poor compliance to insulin. And also during his initial 2 years, he was on OADs, but again, we do not know the nature of control. So this is the case, this is the examination, and this is what we came up with initially during the initial diagnosis. And with Abhishek sir's and Ashutosh sir's permission, may I move forward, or do we need to discuss? I now have a sort of, my next slide is going to be on the differentials. So besides type 1 diabetes, what else did we think of? So Abhishek sir, may I
But I
proceed?
would just like to ask you, the
Yeah.
BMI at the time of presentation, was it also normal? Because I think that was not mentioned. At the time of examination, you told it was normal. So
Yes,
at
sir.
15 years of age, was it normal?
So we did not have the BMI at that
We
time,
don't
but
have.
we asked him grossly about his
Most
weight.
likely.
So yeah,
Okay.
so he mentioned that there was no weight loss as such, but he said he was largely been similar. Like there's been a weight loss of 3 to 4 kgs, but they never said that he was obese as such.
Okay.
Yeah.
So that will be also favoring type 1 diabetes, and there must be absence of insulin resistance markers at the presentation. Again, that will be for favoring type 1 diabetes.
Yes, sir.
So as of now, it looks more towards that. But yes, history of decay is not there.
Right,
And
sir.
We are still not sure. Yeah.
yeah,
Right. So again, one peculiar thing that we did find with this young onset diabetes, young onset diabetes was that one was this history of sensory neural hearing loss. So whenever we have a patient with young onset diabetes, specifically who does not have a history of decay, there should be a few blinkers which should ring in our head, and that was one of the things that that we thought. So essentially, there are 3 to 4 differential diagnoses that we think specifically when a young age onset individual presents to us with diabetes and deafness. So one is, of course, your maternally inherited diabetes with deafness, that is due to mutations in your arginine and glutamine. But again, it has typical characteristics of it being maternally inheritable with maculopathy present on your fundus examination. The diabetes phenotype in this usually resembles your type 2 diabetes, and around 83% are insulin independent, and diabetes is also very rare. Again, age of onset tends to be relatively late. That is at around, the average age is around 37 years of age. So when you look at this patient phenotype, there was no maternal history, there was no maculopathy, and this is a patient with a very young age compared to this. The other differentials which should ring in our head, one is Wolfram syndrome. So this is an individual who will present to you with diabetes mellitus, optic atrophy, diabetes insipidus, and sensory neural hearing loss. So these are the characteristic 4 manifestations. But again, this individual is insulin dependent, but when we look at our case scenario, there was no history of diabetes insipidus, which is at times present. There was no history of optic atrophy, which is very common, seen in around 82% and usually occurs by the age of 10 years. And we had this individual at around 23 years and there was no optic atrophy. And also there were no neurological manifestations in this individual. Now, the third category, which is very rare, is something which is known as Rogers syndrome. So this is thiamine responsive megaloblastic anemia, which is presents with a triad of megaloblastic anemia, diabetes mellitus, and sensory neural hearing loss. And again, this occurs at a very young age. Decay has been reported, and there's been cases of remission with thiamine. Again, there was no anemia in the picture. There was no megaloblastic anemia as such. So again, this does not fit our profile. So considering a diagnosis of type 1 diabetes, just to confirm the diagnosis, what we did was, as one would do, we got anti-islet cell autoantibodies done. And interestingly enough, we got 4 antibodies done. That was GAT65, IA2, insulin autoantibody, and anti-islet cell antibodies, and they came out to be negative. I would just like to mention that we did not get a ZNT8 done. But again, if I have to highlight islet autoantibodies in type 1 diabetes, they are positive in around 90 to 95% of type 1 diabetes. They can be negative in individuals with type 1 diabetes. But in this study, which has been mentioned in this review, which was mentioned by Rossi et al., as you see in this figure, in this the number of antibodies and the positivity percentage, in individuals who have around 4 antibodies tested, the positivity percentage increases substantially to around 81.6%. And in our individual, despite us getting 4 autoantibodies done, he was negative. And one more thing that I would like to highlight is that with increasing age, the prevalence of autoantibody decreases. However, GAD65 is still positive in around 60 to 65% individuals, even after crossing 20. So again, this was again negative. So we have an individual with a possible suspicion of type 1 diabetes with negative islet autoantibodies. So the next thing that we thought of, specifically with regards to the sensory neural hearing loss, we got a genetic testing done. And why did we get the genetic testing done? Because this is now there in the 88/2024 guidelines as well. So I'll just like to mention the indications for genetic testing. So monogenic diabetes should be considered in those with one or more of the following features. So if you have an age of onset of diabetes which is less than 35, or if you have a HbA1c which is less than 7.5 or around that area at diagnosis, if you have any parent with diagnosis, if you have features which are suggestive of a specific monogenic cause, such as if you have renal cysts, if you have partial lipodystrophy, if you have maternally inherited deafness, or if you have severe insulin resistance in the absence of obesity. And the last feature being a monogenic diabetes prediction model probability being more than 5%. So out of these features, when I look at my case, there were two things that he specifically fit into. The age of diagnosis was less than 35 years. And we also calculated this monogenic diabetes prediction model in which his risk came as high as 75%. So this is a model which was developed initially in a study by B.M. Shields et al. And what they did was they basically applied logistic regression on 1,200 individuals who had either MODY, type 1 diabetes, and type 2 diabetes. And what they found was that these models largely improve the sensitivity and specificity for identifying MODY compared with the standard criteria for diagnosis. This standard criteria is something that I'll be discussing during my review of literature. But we all are aware of the criteria for diagnosis of MODY, where the age of onset tends to be less than 25 years. They have preserved insulin secretion and there's a strong family history. So they went on to suggest that apart from using the criteria, you can also consider using this model, which largely improve the sensitivity and specificity. But again, this model has a caveat that it's been validated only in the European population. We have to be sort of wary when we apply it to our Asian subgroup. But for our patient, the prediction was around 75%. So we then went ahead with a mitochondrial genome sequencing, specifically in view of his diabetes. And we also got a clinical exome sequencing. And interestingly enough, we found no mutations in the mitochondrial genome, but there were two mutations which we found. One was a glucokinase mutation, which was, again, as we all are aware, is suggestive of MODY type 2. And interestingly enough, there was one more mutation in the KCNJ11 that was suggestive of MODY type 13. Now, the MODY type 2 mutation was pathogenic, while the KCNJ11 mutation was of uncertain significance. Now, what is the significance of this is something that I'll want to draw your attention to. So, whenever we are interpreting any genetic report, there's basically a 5-tier system for classification of sequence variants. So you classify them in decreasing order in the form of them being pathogenic, likely pathogenic, uncertain significance, likely benign, and thereafter benign. Now, there's a set algorithm which is used by the American College of Medical Genetics and the Association of Molecular Pathology. I would not want to go into the depths of this, but just one thing that I want to specifically highlight is that the mutation in KCNJ11, which was mentioned as uncertain significance. So we all are aware that with MODY, we are discovering newer gene mutations which are of relatively sort of newer upcoming mutations. And the uncertain significance mutations in essence means that it's reported as variant of uncertain significance because of lack of literature evidence. So it has to be interpreted in the context of patient's clinical picture to distinguish between variants that might potentially cause the patient's disorder or those that are incidental finding. In our patient, what we can possibly do is we can do a genome sequencing for the parents or for the family members. And if we do find similar mutations, it would further ascertain the fact that this is probably, yes, this variant is of significance. Now, the final diagnosis that we eventually came out with was a 23-year-old male who had diabetes mellitus for the past 8 years with normal BMI, with right-sided sensory neural hearing loss, who was characterized as MODY, that is diagenic diabetes due to mutations in glucokinase and KCNJ11, with poor glycemic control, with distal symmetric sensory motor polyneuropathy, with microalbuminuria, and bilateral posterior subcapsular cataract. So this was the eventual diagnosis that we came out with. Now, we went ahead, and as I had highlighted, that there was a caveat which we mentioned in the family history. So when we asked him about his family, he did not say that any of had diabetes, but we called his father and his mother. And incidentally, his father had sugars of 450, and his elder brother, that was around 29 years of age, also had diabetes with a fasting blood glucose of 136. So again, this went on to prove that the significance of genetic testing in this individual again helped us in identifying family members, and him and us helped us in classifying him as the right sort of type of diabetes. His father was 50-year-old with a BMI of 24.9. He was incidentally detected, and his sugars, as you can see, were sky high with 448 and 550. HbA1c was 15.7, and his C peptide was 1.49 nanogram per ml. So again, this was the beauty of this case, that we sort of moved from type 1 to monogenic diabetes, which had diagenic diabetes in the form that there were two mutations. And this then helped us with our treatment as well. So this was the part of the case. And if we are open for discussion, we can discuss, or I'll move ahead with the review of literature, as you say.
Parth, when he was first diagnosed,
Yes, sir.
possibly C peptide may not have been available at that time, and ketones were also not tested. But on the clinical examination, young age onset, severe diabetes, some degree of weight loss, he was started with the insulin, considering it as to be a type 1, right?
Yes. Yes, sir. Initially, he was started on OAD, sir. When he presented in 2015, he was started on oral anti-diabetics for 2 years, the nature of which he did not mention. But after 2017, when he was admitted with infections and sugars of which were high, then he was started on insulin, sir, basal bolus.
He has not started with the insulin right from the beginning. First, he was put on an oral anti-diabetic for 2 years, right?
Yes, absolutely, sir.
At that time also, he was not being considered as a type 1 also, right?
Yes, sir. Yes, sir.
So,
But
young
at that,
onset type 2
but sir, at that time, it should have been considered as type 1 because at
Type
the
1.
age of 15, we
Yes, sir.
consider it type 1.
Right,
Yes.
sir. That is true.
But because of the availability of the C peptide at all the places, many of the time we miss it as a type 1.
Yeah, so we got the C peptide done when he presented to us, so that was after considerable time. So that came out to be 0.69. But yes, sir. But again, he had episodes of hyperglycemia. So even that C peptide is not very reliable as such. But we got it done at a fasting C peptide after achieving a relatively good control. But he had episodes of hyperglycemia even prior to presentation, sir.
So
Yes.
was he not given sulfonylureas at that time at the initial stage, or the record is not available?
Actually, sir, the record was not available.
Because, sir, I
Yes.
think sulfonylureas work in such type of cases for a few time.
In
For some time.
certain,
Yes, sir.
Absolutely, sir. Very true. I think even they are very cost effective and they tend to work very, very
Yes.
well.
Yes.
Yes.
Not only cost
Sir,
effective,
one
but give a
question.
quick relief if we can stop the insulin of the patients.
Yes.
Yes, sir. Yes. So they are directed towards specific modies, which I'll highlight, sir. Yes. Sir.
If there is any recommendation for the family screening of the diabetic patient, if the first time they come to us with the diagnosis of diabetes, is there any recommendation for any family screening like this?
So
if father
there's
is
no
suffering
recommendation for
from such
family
high blood-
screening as such, but there are general recommendations in the ADA guidelines for when should screening be done. So in that, I think most of the Indians would sort of fit in. Like if the age of onset is more than 35 years, if there are any markers of insulin resistance, if there's been any history of GDM, if there's any family history of diabetes. So there are specific indications for screening after, age being one that they put at the top. So thereafter, for those cases, we should specifically consider doing a screening, sir.
Family history, otherwise, it's very important for all the diabetic patients.
Very
When
true, sir.
I just entered in the practice in 1995, I found a patient, a young female patient of obesity, and I found severe acanthosis nigricans, and his father was brought to along, who brought the patient was having acanthosis nigricans. So I told him that just to go for the blood sugar and lipid profile, and both were abnormal. So family history and clinical examination can sometimes be rewarding. Just by
Absolutely.
children, we can find out problems in the adults also.
So I recently had a patient at Kota Heart. So she was a 33-year-old female who had presented with a CAD, and she had very uncontrolled diabetes for the past 10 years. The age of onset was 23 years, and the family history was very strong. And she was on insulin at that time. I again got a genetic testing for her done, and she came out to be MODY 3, sir. So I switched her to sulfonylureas, and it's been 20 days after I've switched her, and as of now, the response has been very good. So that's, I mean, and I got the genetic testing done primarily because of the family history. So her father, grandfather, and in her paternal sort of relatives, they had a strong history of diabetes. And all of them, I mean, around sort of 3 to 4 of them had a young onset of diabetes in around 30s to 40s.
Yes.
Yes.
Then family history, we should take a MODY also into consideration.
Yes.
Really young patients.
So now coming to the review of literature. So when I talk about monogenic diabetes and specifically numbers, so the first number that I want to draw your attention to is something which has come in the recent ADA. And they say that the misdiagnosis is common and can occur in around as high as 40% of adults with new onset type 1 diabetes. So this means that uh, adults with type 1 diabetes are misdiagnosed as having type 2 diabetes, or individuals with MODY who are misdiagnosed as having type 1 diabetes. So the misdiagnosis is as high as around 40%. And when I talk about monogenic diabetes, the sort of prevalence is around 4% in those diagnosed less than 30 years of age. And its likelihood increases to 20%, specifically when the islet antibodies are negative and the C-peptide secretion is maintained. Now, this is from the National Youth Registry. This was done by a study by Nikhil Tandon sir and et al. And what they found was that in individuals who were enlisted as having diagnosed diabetes in less than 25 years, of course, type 1 diabetes was the most common. Type 2 diabetes following it, but other variants such as MODY was seen in 3%, and GDM was seen at around 3.9%. Now, and when I talk about monogenic diabetes, it can broadly be divided into defects in beta cell function, wherein we look at features like MODY, neonatal diabetes, and mitochondrial diabetes. And then there are defects in insulin action. There we look at rarer syndromes like leprochaunism, Rapson-Mandelhaus syndrome, or congenital lipodystrophic diabetes. Now, when I go back to MODY and when I go back and look at the criteria for MODY, it came way back in 1974. And this was famously known as the Tattersall and Fajans criteria. This has now been modified, but at that time they went on to define, and a very significant, sort of very high significance was given on the absence of ketosis and a strong family history, which was autosomal dominant and non-insulin dependence even after 5 years of diagnosis. Of course, this has now been modified, and the current criteria, which is that the age of onset is ideally less than 25 years, where the presence of diabetes is seen in 2 consecutive family members. Autoantibodies are absent, and the C-peptide is usually more than 0.6 nanogram per ml. So when I talk about MODY specifically, it's very common with 14 different genetic mutations, with the most common ones being HNF1 alpha glucokinase and 4 alpha. And here is a whole list of MODY, which I'll not go into the depths of, because I'm sure we all have to go through this once we see a particular case. But the mutations that came in our case were, of course, MODY 2. Now, MODY 2, interestingly, is very mild. Again, this is the significance of diagnosing MODY, that in individuals who have MODY 2, which is the most common subtype in India, it has very mild fasting hyperglycemia, and most often it does not even need any treatment, and diet alone can suffice. When we look at other forms of MODY, such as MODY 1 or MODY 3, sulfonylureas tend to work very well. There's no role of metformin. There's no need of insulin as such. While MODY 4 and 5, which are also relatively common, need insulin at times. Other variants are very common, but are very rarely seen. But the second mutation that we saw was MODY 13, that is KCNJ11. So this was a diagenic diabetes wherein we had 2 mutations. And when we specifically look at one mutation, that is glucokinase, it tends to be very mild. However, our case had presented with relatively higher levels of blood glucose with a relatively high HbA1c. So this is wherein the significance of diagenic diabetes, that is, even Modi at times can have two mutations, and the second mutation, the KCNJ11 mutations can present with deafness, and they are often insulin requiring. So as was seen with our case. So with glucokinase mutations, as I have mentioned, that there's an increased glucose threshold. This is the most common subtype which is seen in India, and it usually tends to lack complications. While and it does not as such require anti-hyperglycemic therapy. While when I talk about KCNJ11 mutations, they are more common in neonatal diabetes. So individuals who have permanent neonatal diabetes, they have a mutation in the KRI 6.2 outer inner pore, and that leads to these mutations which require insulin, and they more often cause neonatal diabetes. But of course, they have also been described with Modi. So this is just a summary of some of the mutations that have been specifically been described for KCNJ11. Now, I would not go into the depths of these case reports, but what I would want to highlight is that almost all of these individuals, you look at the study which was described by Binmin, Echi et al., individuals who were eventually switched to sulfonylureas achieved excellent glycemic control. And so sulfonylureas is something which is very effective, tends to work very well. And in accordance with insulin, they can help. And there's no need of other therapies like metformin or even SGLT2 inhibitors or DPP4 inhibitors. And when I look at diagenic diabetes, so the majority of cases of diagenic diabetes occur due to combination of the more commonly occurring genes such as SNF1 alpha, glucokinase 4 alpha, or 1 beta. And when I look at the case reports which have been described, one thing which has been seen across these case reports is that they tend to be relatively more severe. You look at the second case which was described by Forlani et al. So again, they had a severe form of diabetes with a younger age of presentation, and there was an early need of insulin therapy in this child who was diagnosed at 17 years of age. So again, what we sort of probably infer from these limited case reports which we have seen is that diagenic diabetes at times can give a more severe presentation. It might be insulin requiring, but again, sulfonylureas in accordance with insulin is something that you need to consider. So, but again, long-term cases are needed. We are in the we are in the process of publishing this case, and this has been accepted provisionally. So, I would just like to end with something which is been given in the ADA 2024 guidelines, and this is an excellent flowchart as to how we can approach young onset diabetes. So, for any adult who is a suspected type 1 diabetes, as and when possible for us, I understand there are financial constraints, but as and when possible for us, we should get islet autoantibodies done. If it's positive, of course, it's type 1 diabetes. However, if it's negative, which can be there in 5 to 10% adults with type 1 diabetes, you should look at the age. If the age is less than 35 years of age, you should look at the features of monogenic diabetes. If the features of monogenic diabetes, which I had highlighted in my initial presentation, if they are present, you should get a C-peptide done. C-peptide, if it is more than 0.6 nanogram per ml, or if it is more than 200 picomole per liter, you should consider doing a genetic testing for monogenic diabetes wherever possible. However, if your C-peptide is low, and if there are no monogenic features of diabetes, you can consider potentially a diagnosis of type 1 diabetes, which is antibody negative. And of course, if there are features of type 2 diabetes, you should consider making a diagnosis of type 2 diabetes in that individual as well. For the individual in whom you are considering a diagnosis of type 2 diabetes, what you can possibly do is you can consider doing a C-peptide after discontinuing your insulin for 3 years. And if it comes out to be more than 1.8, that is more than 600 picomole per liter, you know that this might largely be your type 2 diabetes. So when I talk about this patient, we are planning to get a single sequencing done for the variants in the family members. At his last OPD visit, that was October 2023, he was on basal bolus insulin. We were about to start sulfonylureas. His HbA1c was 8.1. So with this, I'll end my presentation with a few take-home messages. So the first take-home messages would be we should always look at the clinical history wherein age, family history, a history of other specific clinical pointers such as deafness or abdominal pain, steatorrhea can point to specific etiologies of diabetes. Family screening is very important in terms of implications. Genetic testing should be considered whenever possible, specifically when the autoantibodies are negative. Now, from diabetes, we are moving towards a personalized approach wherein each individual, depending on the type of broad spectrum of mutations, there's an evolving phenotype. Now, we all are aware that there are as many as 10 to 15 subtypes of diabetes. So you have to tailor your therapy accordingly. I would like to thank my teachers at AIIMS, Dr. Ravindra Shukla sir, Dr. Madhukar Mittal sir, Dr. M.K. Garg sir, my seniors and my colleagues and juniors there, and specifically Dr. K K Pareek sir, Dr. Girish Mathur sir, Dr. Prakash Keswani sir, and Dr. G D Ramchandani sir for giving me this opportunity to present this case. It's been a pleasure. Thank you.
Thank you, Dr. Parth, for your good presentation. It was really a good case. Initially thought to be a case of type 1, and later on came out as to be a monogenic diabetes. And again, the take-home message is very good, that all young patients should not be considered as type 1. And this similar kind of the case was also presented previously by the Dr. Arvind Gupta. And that patient was being treated for as a type 1 for last 15 years. And later on, when he was, initially when the patient came with uncontrolled diabetes, C-peptide was also low. That may have been because of glucose toxicity. And later on, C-peptide also got increased and was considered as a type 2. But your patient was of different phenotype and young patient. And we should think of other causes. But the flow chart you showed is go for the antibodies initially, which is not feasible even as on today for us to go for all the patients. Rather, still we think of going for a patient comes to the young patient with a type with an uncontrolled or very high diabetes. We simply go for the urine ketones and C-peptide. And with that only we start treatment and keeping other things in mind. And later on, if we really think of monogenic diabetes or something, and then we go for the genetic testings. Abhishek, what is your opinion?
First of all, excellent case presentation by Parth, and it is very important that when we are dealing with a young onset diabetes, we should look for other pointers, like he already told regarding the other features that were present, like deafness in this case. And many times, he told about the Did-Mode syndrome or the WFS1 gene. So in that case, also I had seen 1 or 2 cases at Delhi. And in that, there was a female who was type 1 diabetic. And as he rightly pointed out, she was, I think, 12 or 13 years old and she was deaf. So initially, we could not make out type 1 diabetes with optic atrophy, but the teachers told us to think, then it was. So same, like if type 1 diabetic or young diabetic is with ear abnormalities or visual abnormalities, we should definitely look for some other syndromic features of them. And in the case reports that he quoted, so I would like to highlight a very important thing which I noticed in all the case reports that he has sent. The history of DKA was absent in many of the Modi series individual cases that he showed. Even in diagenic diabetes, where the sugars were very high, the DKA negative was there in all the slides. So it is a very strong message that if a patient is having young onset diabetes, his C-peptide is OK types, and he is not having any history of DKA, we should think for monogenic diabetes. I think that was the crux of all the case reports that he showed. So
Yes.
that's it. It was really excellent case presentation.
Yes. Ashutosh?
Yes, sir. Really very excellent and interesting case presentation. And I would like to compliment and congratulate dear Parth. And one more take-home message that I can draw, sir, from this case is that about the hearing loss, that we consider a lot of complications of diabetes, neuropathy, retinopathy, etc. But I think that hearing loss is a neglected complication of both type 1 and type 2 diabetes. In the studies, I have read and heard that about 45% of prevalence is there of hearing loss in diabetic subjects. But it is more in type 1. But yes, this was a different case. And as sir was saying that we had previously discussed also some type of monogenic diabetes. So I would like to share it here with sir's permission. That news of that time that monogenic diabetes, when this online CME was considered, at that time the Wolfram syndrome case was presented by, I think, the Dr. Shailesh Lodha sir. Yes, sir. So it was also very interesting case, and today also we had got that another very important case. So I think a lot of take-home messages. First of all, as already mentioned in the flow chart, that first of all, go for the auto-isletsel antibody, then look at the age, consider the age, and look for the symptoms of monogenic diabetes, and then proceed for C-peptide and other genetic testings. And if at all in the management part, if the patient is resistant for insulin treatment, then whether you should give any other drug. Today we can see a lot of prescriptions that we start with the SGLT2 inhibitors or DPP4 inhibitor, but I think still, sir, that metformin and sulfonylureas are very important weapons in our armamentarium. So in these type of cases, if the patient is resistant to insulin, we must consider the sulfonylureas as a treatment in the starting. Thank you, sir.
Thank you. Thank you for your nice comments, Dr. Ashutosh. If there are any comments, Dr. G D Ramchandani, will you like to comment and will like to conclude it?
Thank you, Keswani boss. First of all, it's a big salute to Dr. Prakash Keswani for
not me,
for doing this, all these
all of the
activities.
team,
And we are every meeting we are learning a lot. I still remembering the quotation of William Osler, that a doctor is a student till his death, and when he fails to be a student, he dies. So we are really learning in every meeting by this young generation how to present the cases, and they are truly amazing cases they are coming back, bringing. And second, I would like to congratulate and compliment Dr. Parth for the excellent case, and the way he presented till the take-home message is truly amazing. That's truly showing that the future is very bright, and we would like we also congratulate and say that definitely he's presented in the last 2-3 months 4-5 CMEs, and his overall presentation is excellent. And so wonderful, Dr. Parth. And third thing, I once again have truly, along with Dr. Ashutosh, that we are always talking about all the pathies in diabetes, but we don't have any sympathy. But we must have some sympathy and try to evaluate thoroughly and try to conclude the diagnosis. Otherwise, we are missing, especially in young diabetics. It's very, sometimes it's situation is very tricky, whether to start insulin or continue insulin, and we try to start because we don't have much of the facilities to differentiate all these Moody type 1 and type 2 and all these cases. And sometimes patient is taking insulin for quite long time, and sometimes is taking oral. And so in that particular situation, you need, you must have sympathy for patient and try to evaluate. So excellent presentation. And again, special thanks to Dr. Keswani and all the moderators and Dr. Parth and all the delegates who were attending this CME, this today's program.
Thank you, Dr. Ramchandani. Not at all thanks to me, but all of the team, and we have a very good team. Dr. Neeraj, will you like to say something?
Organizing such a nice case series discussion monthly. Every time we got the message from you.
Yes.
The case discussion gives something new knowledge to all of us.
Yes.
Thank you, Dr. Parth, for presenting such a nice case.
Yes, sir.
Thank you.
Dr. Daryar.
Yes, sir. Excellent presentation, Parth. Excellent. It's a really a huge compliment for you, because somebody directly messaged me that bande mein dam hai. How you presented the case from the starting, and even I discussed with Keswani sir before 2-3 months back that if somebody is not presenting, that I can present one of Modi, and even I have sent the PPTs to sir also. But really, it's a very good case, and even in last my cases, I also have discuss with everybody that we should think about if somebody is coming with the young onset diabetes. So if it is a young onset diabetes, it's not only a type 1, type 2, type 3, it can be anything else. So you nicely presented. Thanks a lot, and God bless you for a future endeavors. Thank you, sir.
Thank you, sir.
Thank you.
Thank
Thank
you.
you, everybody. Thank you, Dr. Parth, for presenting a nice case. Dr. Abhishek, Dr.
Thank you, sir.
Ashutosh, Dr.
Thank you, sir.
Neeraj, Dr. G D Ramchandani, Dr. Gwalani Bose, Dr. Geeta Arora, very sincere attendee, and Dr. Mehta, Dr. K K Sharma, Dr. Rajendra. Thanks to all of you for being a part of this program. And bye-bye with this. And we
I would like to
conclude it
share
now.
one more thing, that Dr. Parth Jetwani is the son of Dr. J.L. Jetwani. He is the senior physician of Kota, is a batchmate of Dr. Girish Mathur. So
Acha,
he
oh,
has
that's
worked under his guidance for past 20 years. And now see how the new generation is coming, and they are teaching us in a new good cases. We will learn a lot from Dr. Father and son both. Thank you, Parth. जेठवानी बॉस ने खूब हमें गाइड किया है, एंड आपसे भी खूब चीजें सीखेंगे हम लोग फ्यूचर में.
नहीं सर, मैं आपसे सीख.
He is a very popular physician of Kota, Dr. Jetwani sir.
So bye-bye, everybody.
Thank you, sir.
Thank you, sir.
Thank you,
Thank
sir.
you.
Bye-bye.
Thank you.
Good night, sir.
Again.